In this session, we will be going over the high yield topics of upcoming NEET PG exam of biochemistry. Myself, Dr. Varsha Gupta. So, welcome. Like everybody who is here is most welcome. Please listen carefully and make down the notes. I'm taking few clinical case scenarios, and I'll discuss all the options and also various other possible combinations which could be given in the exams, because most of the times conditions are so similar and we have hard time figuring out which one is the most appropriate answer to this. The first question is about a 12-month-old girl with progressive muscle weakness, right? And the cardiomegaly is there. Muscle weak are there, baby is there, cardiomegaly is there, and there is liver is enlarged, and the lysosomes, prominent lysosomes filled with cluster of electron dense granules, right? What does it mean? That we are referring to lysosomal storage disorder. Those lysosomes are your recycling or residual bags, where whatever needs to be degraded or recycled in the cell comes, and there are lysosomal enzymes which work best at the acidic pH. Lysosomes are the organelles which have the acidic pH, right? And like pH lower than the normal pH of the blood, right? And things are being degraded over there. Okay, so this is if lysosomes are being accumulated by something, means there is a chemical entity or compound, right? Maybe it's a protein, lipid, or something that is not being degraded properly, and that has a complex structure. So it is a huge, maybe a lipid, it may be a big protein, or it may be a big carb, right? Something is there like that with cardiomegaly, right? And parents are told that the death is within 1 to 2 years. We know few facts: lysosomal storage disorder, cardiomegaly, baby we are talking about with the muscle weakness, and the death within 1 to 2 years, right? So you have four options: glucose 6-phosphatase, alpha glucosidase, hexosaminidase, and glucocerebrosidase. This is glycogen storage disorder. No cardiomegaly we see, and we don't see the early death. That's a von Gerke disorder. Glucose 6-phosphatase is what? Glucose 6-phosphatase convert glucose 6-phosphate into glucose, and this is an endoplasmic reticulum enzyme. Glucose 6-phosphatase is an endoplasmic reticulum enzyme, and that is found in the not in the lysosome. So this is not a possibility. That is leading to hypoglycemia actually. What do we see in von Gerke disorder? Von Gerke disorder, we see hypoglycemia, lactic acidosis, right, and doll-like feces, and round abdomen, right? Round abdomen is being seen. So this is not an option. First three options, all these options are the lysosomal storage disorders, which are categorized as like alpha glucosidase. Alpha glucosidase is deficiency is leading to your Pompe disorder. Pompe disorder. This is a glycogen storage disorder, as similar to the glucose 6-phosphatase. The von Gerke is also glycogen storage disorder. Pompe is glycogen storage disorder, the only glycogen storage disorder which is actually a part of lysosomal storage disorder. Lysosomal storage disorders are of various kind. In fact, if these all are lysosomal storage disorder. I have a made for list for you. Mucopolysaccharidosis. Mucopolysaccharides breakdown deficiency leads to enzymes that are involved in breaking down of mucopolysaccharides are creates lysosomal storage disorders. Your Pompe disorder, which we have just saw, it is actually a glycogen storage disorder, but the lysosomal storage disorder. Sphingolipidosis, the Hurler syndrome, Hunter syndrome, Wolman's disease, cystinosis, mucolipidosis, in which we study about the eye cell disease. glycoproteinosis. All these are lysosomal storage disorder. So Pompe disease is a glycogen storage disorder, which is actually a lysosomal storage disorder because of the deficiency of alpha glucosidase enzyme, because of the deficiency of the alpha glucosidase enzyme. And the clinical features, if we talk about the clinical features of the Pompe disease, that is heart cardio, biggest one is cardiomegaly or cardiomyopathy, right? And the patient usually die within the 2 years. So this is actually the answer for this question. Glucocerebrosidase, hexosaminidase, these are also lysosomal storage disorder, but these two are sphingolipidosis. Right? If you have to compare them, right, sphingolipidosis, what do we know? Like you have what is given, the hexosaminidase. A. If this enzyme is deficient, that leads to the Tay-Sachs disorder. Tay-Sachs disorder. Right? Other option is glucocerebrosidase. Glucocerebrosidase. If this enzyme is absent, that leads to the Gaucher disease. Gaucher disease. That leads to the Gaucher disease. Gaucher disease is most common sphingolipids process. Most common. It is most common. Right? Tay-Sachs is because of hexosaminidase 1. Hexosaminidase 1, A has the another variant, another isozyme, hexosaminidase B also. So if both hexosaminidase A and B are absent, that gives rise to Sandhoff disorder. Sandhoff disorder. Okay. So in Tay-Sachs disorder, what we find is the patient, the question will give you the cherry red spot, whereas in here you don't see cherry red spot. Okay, what else will be there? There will be mental retardation. In most of the sphingolipidosis, be it a Tay-Sachs, Gaucher, and we will gonna see more, they all will be having mental retardation, but in Gaucher usually you don't see that mental retardation. You really don't see that. What else is seen in the Tay-Sachs disorder? Tay-Sachs disorder, death is within 2 years. But in the question, no cherry red spot was given. So, and no hepatosplenomegaly. No hepatosplenomegaly. So that's why we never picked this choice, right? We never picked the choice in the question. So you should be looking for the cherry red spot and like no hepatosplenomegaly thing was there. There is one more disorder, Niemann-Pick disorder. Niemann-Pick disorder is because of the deficiency of sphingomyelinase enzyme. In this, if you compare Tay-Sachs with the NPD, usually in the question paper, in the clinical case scenario, you have to pick either of these two ones, right? In both of them, you have the cherry red spot. In this also, you have patient is suffering from the mental retardation and also early death. But what else you will see in this is hepatosplenomegaly. And what else will be there if you look at what else would be there when you are going to look at the inside the cell? In the Niemann-Pick disorder, you will find the onion rings. Where in the Gaucher you will see the crumpled tissue paper appearance. These are the keywords you should be looking for in the given clinical case scenario. Cherry red spot with hepatosplenomegaly, cherry red spot without hepatosplenomegaly, crumpled tissue paper appearance. These three are most frequently asked in the exams over and over, other than the Pompey's disorder. And if you look at the cell, if you look at the cell, if you look at the cells, that's how they are going to look like. Okay, so here is this one is the Gaucher disease, where you see the crumpled tissue paper appearance, right? And then you have what macrophages, lipid-laden macrophages. In the Niemann-Pick disorder, you just see the lipid-laden macrophages, but no crumpled tissue paper appearance. In the Tay-Sachs disorder, you will mostly find the cherry red spot and the onion rings in the onion rings. Here we have, what have we have? We have the zebra bodies. They usually we see in the Hurler syndrome. That is the another kind of the lysosomal storage disorder, but that is a mucopolysaccharidosis. This Hurler, which is mucopolysaccharidosis. Hurler and the Hunter syndrome. But now we are pretty much like clear about the Pompey's disorder, which is actually a glycogen only glycogen storage disorder which is categorized under lysosomal storage disorder. We now know the three major sphingolipidosis: Tay-Sachs, Gaucher, Niemann-Pick disease. There are another sphingolipids also, deficiency of like breakdown of those sphingolipids, those are which are lipids, leads to the diseases, because the enzymes, these lipids are going to get degraded in the lysosomes by the lysosomal enzymes. For example, if there is a deficiency of galactosidase enzyme in the lysosome, that is going to give rise to the Fabry's disease. And Fabry's disease, it is the only sphingolipidosis which is XR in inheritance. It is not autosomal dominant, it is not autosomal recessive, but X-linked recessive in inherited, right? And as I have told you, all the sphingolipidosis, as you can compare from this chapter, this also, they will be related to the mental retardation. Some kind of a neuropathy will be seen over and over in all of them, except you won't see in the Gaucher disease. Right, in the Gaucher disease, they will be having this. So you cannot compare by this. You have to get the other measures to do it. In the Fabry's disorders, what you will find it in the early stages is divided into two phases. The early stages, it is a triad of peripheral neuropathy with angiokeratomas and hypohidrosis, whereas the later stage, the patient is facing the acute renal failure and the cardiac issues. Enzyme deficient is alpha galactosidase enzyme, right? Then is the metachromatic leukodystrophy, which is because of the aryl sulfatase A. There is another aryl sulfatase B, which is different than this one, and that is categorized under the mucolipidosis. I will come back to that again. That is a type of MPS, that is not a type of sphingolipidosis. So in rush, don't pick the wrong answer. Okay, then you have the metachromatic leukodystrophy was asked last year in the question paper, right? So I'm not hoping they are going to ask it again so soon, but just know it. Krabbe's disease is what you see in this. In Krabbe's disease, that is because of the galactosidase deficiency, right? And what do we see? We see the globoid cell, right? We see the globoid cell. How actually, if you have to look at the map, at the degradation of the map, first of all, understand how they are being formed in the body, right? Sphingolipids. Sphingolipidosis is because of the word sphingolipids. Sphingolipids. Sphingolipids are the lipids which contain an alcohol known as sphingomyelin, sphingosine, or sphingosine. When this sphingosine gets fatty acid, but this sphingosine gets a phosphate and a group that we have studied in the lipids chapter, maybe it is a choline or ethanolamine, right? It makes what? It makes sphingolipids, right? And degradation of these results in all kind of sphingolipidosis issues. The basic unit is like sphingosine here. Sphingosine, this was once asked, sphingosine combined with fatty acid gives you the ceramide. So we can call ceramide is the basic unit. Then you have a phosphoric acid attached right here to the alcohol. Sphingosine is an alcohol, is a kind of alcohol. Another kind of alcohol is a glycerol, which composes your glycosaminoglycans. Okay, but these are your sphingolipids. And then here in this group is the choline. This may vary from one to another one, from one sphingolipid to the another sphingolipids. The complex, very complex sphingolipids are your gangliosides, and the simplest ganglioside is your GM3. Yes, we expect it to be GM2, but the simplest one is GM3. The complex, then more complex is GM2, or in another way I can say GM2. If you break down GM2, you can get GM3. If you break down GM3, what do you get? You get glucocerebroside. And if you break down further glucocerebroside, what you get? Ceramide. Ceramide is the smallest unit. There is another thing, as similar to glucocerebroside, you have the galactocerebroside also, which breaks down to give you the ceramide. Similarly, you have sphingomyelin, which breaks down to gives you the ceramide, right? Other thing you have is ceramide, a kind of a ceramide, trihexoside, which breaks down to give you glucocerebroside. So you have so many kinds, and they all require some kind of a particular enzyme, and that degradation and deficiency of those enzymes, these all are inborn error of metabolism. The deficiency of any of these enzymes is going to give you a disorder. GM2 to GM3, that is taken care by the hexosaminidase, and disease is the Tay-Sachs disease. Tay-Sachs disease. Glucocerebroside to ceramide is glucocerebrosidase. And deficiency of this will lead to Gaucher, the most common one. Glue-Gau, most common with the crumpled tissue paper appearance. Sphingomyelin to ceramide is sphingomyelinase. And this is your Niemann-Pick disease. Deficiency of this will lead to the Niemann-Pick disease which we have just seen. Galactocerebroside to ceramide. Enzyme is galactocerebrosidase. And if this enzyme is deficient, what do you lead? It leads to the Krabs disorder. It leads to the Krabbe disorder. In any way, whatever way you want to pronounce it. Right? Ceramide to trihexoside. Ceramide to trihexoside is this alpha galactosidase A. And the disease is, deficiency disease is Fabry's disorder, right? The one we are left with one, that is metachromatic leukodystrophy. That is, we have a huge complex sulfatide, right? And Aryl sulfatase is the enzyme. Aryl sulfatase A. Remember this, I'm telling you over and over. Aryl sulfatase A, deficiency of this enzyme leads to what? Metachromatic leukodystrophy, which was asked last year in the question paper. So these are all the enzymes, their related diseases. Now you know how to figure out the differences between them, right? I told you about the Sandhoff disorder. Very similar naming to Fabry's disorder is a Farber one. There is a one Farber disorder in which what you have enzyme deficiency, that is ceramidase. That is ceramidase. Ceramidase is deficient, and accumulation, and that leads to very coarse voice, hoarseness on the voice. That is the Farber's disease. Okay, so now pretty much about the sphingolipidosis, right? What other lysosomal storage disorders we were looking for? We know the sphingolipidosis now. We know Pompey's disease. We have mucopolysaccharides also. What are mucopolysaccharidosis? These are your Hunter syndrome, Hurler syndrome. So first know what is a mucopolysaccharide. Mucopolysaccharides are your GAGs, are your glycosaminoglycans, are your glycosaminoglycans. These are your GAGs or mucopolysaccharides. They are one and the same thing. If they join with a core protein, what they make is they make proteoglycan. They make proteoglycan. And this structure is so complex, and it is found in the basement membrane. When you have to make so much of the connectivity loop, it is found with the collagen, the elastin, the fibronectin, like you found those proteoglycan there. And this was the question in the exam about the proteoglycan, the properties of the proteoglycan. What are the properties of the proteoglycan, right? Proteoglycan acts as a packing material. Packing material. Substance in the connective tissue. It can absorb or hold is the better word, hold large quantity of water. Large quantity of water. Why it can hold? It has lots of hydroxyl group, and it has too much of the negative charge, right? And it can attracts the, it keeps the carbs away because of the repulsion. So there is too much of the space in between where water can be retained. So it forms a gel kind of a cushioning kind of a effect. And also you can say it provides the turgor, right? That is why it is found where in the connective tissues, where you have the collagen, fibrillin, fibronectin, all laminin, all those things are there. There you found the proteoglycans, right? There you find the proteoglycans. So coming to first of all the GAGs. This was the question about the property of the proteoglycan. They hold large quantity of water. They are the packing materials. They have the negative charge on them, right? And they bind to, if you want to write down, they bind to elastin, collagen, fibronectin, fibronin, laminin, right? All of them, they were there, right? And they act as a gel. They act as a gel since they can hold lots of water and they have the negative ions. So they attract the polyanions also. They attract the positively charged ions towards them. So they are osmotically active as well. So this was once asked in the exam. Another question related to this was the properties of the glycosaminoglycans. So know what are glycosaminoglycans. You have hyaluronic acid, chondroitin sulfate, keratin sulfate 1 and 2, heparin, heparin, and heparin. Both are two things, different things. Dermatan sulfate. Heparin is your anticoagulant. It works with factor 9 and it works with factor 11, right? Pre-prothrombin, where it networks you see. Heparin sulfate is found in the connective tissues. In the connective tissues. What it does, it provides the cell-cell adhesion, cell-cell communication, all those things the heparin sulfate does. Okay, so hyaluronic acid was once asked, and once the chondroitin sulfase was asked. Hyaluronic, they asked you which one is found in the synovial fluid vitreous humor. That is the hyaluronic acid. Chondroitin is found in cartilage and CNS. Keratin sulfate is found in cornea, cartilage, and the connective tissues, loose connective tissues, right? Not so much asked, but you should be knowing hyaluronic, chondroitin sulfate. These are very, very important. Now, there was one time when they asked you about the structure. They asked you about the structure of the one, right? So hyaluronic acid, right? Chondroitin 4-sulfate and heparin. What they are? They are the GAG. They are the GAGs, right? GAGs are what? These are the complex car, and they have a repeating disaccharide unit. Like disaccharide is repeated over and over, right? And what they have in common is they have one amino sugar. It can be any kind of amino sugar with uronic acid, any kind of uronic acid. That is the basic structure. So if you look at the hyaluronic acid, see, glucosamine is the amino sugar attached with glucuronic acid. For the chondroitin sulfate, what you have, galactosamine sulfate is there for the chondroitin for sulfate, and that is attached with glucuronic acid. For the heparin, what they have the glucosamine, sulfated glucosamine and sulfated iuronic acid. Heparins are the one which are the most sulfated. Heparins are the one which are more sulfated. Now, when these gags, they are complex polysaccharide, they are in the form of a chain. They bind to a core protein. They make what? They make the proteoglycan, which is found in the cell basement membrane for the connectivity. So this is the electron micrograph of the proteoglycan. You can see how complex and how a webby kind of a structure it is. Not exactly webby, the ends are loosed, but you can see the mesh of network is there. Cartoon diagram is this. This is an example of the proteoglycan, in which this is the hyaluronic acid attached to this. Hyaluronic acid is the black kind of a thread that is going on. That is a polysaccharide chain, which is what polysaccharide is. This complex carb is this hyaluronic acid, which is attached to what? Core protein, which is attached to the core protein via the link protein. And the green ones are what? These green ones are again different kind of gags. So this is like very complex structure, proteoglycan, but you should be able to label all of them for examination. I have seen that question, I guess somewhere in the, for AIMS I have seen it, right? I don't remember the year, but it was there. So you should be knowing the structure. You should be knowing the structure of the proteoglycan, composition, and where they are being found, and the diseases associated with them. The major one we talk about is a Hurler syndrome and the Hunter syndrome. Use this space, right? So mucopolysaccharidosis 1 is your what? Is your Hunter syndrome. You have the Hurler syndrome, is your Hurler syndrome. Mucopolysaccharidosis 2 is your Hunter. Very, very important. We have another ones also, MPS 3, which are of 4 categories. MP3, MPS 3A, 3B, 3C, 3D. So let's first focus on the MPS 1, Hurler syndrome. Hurler is because of enzyme deficiency L. Just remember in this alphabet L, and in this remember T. That will make your life very, very easy. L stands for L-ide uronidase. That is alpha I uronidase. In MPS 1 and MPS 2, in both the MPSs, you have dermatan sulfate and the heparan sulfate. They are being precipitated. Enzyme deficiency is L-ide uronidase. L-ide uronidase. In the Hunter syndrome, the enzyme deficient is ide uronate. Uronate 2-sulfate. 2-sulfate. So there are so many TTs. There are so many TTs. Uronate 2-sulfate. That is the Hunter. Name Hunter. Name Hunter means the person is person will be very having aggressive behavior. Aggressive behavior. Whereas in Hurler syndrome, what we are expecting in the patient will be having like the developmental delays, right? There will be skeletal abnormalities. Airway obstruction would be there. And hepatosplenomegaly. Hepatosplenomegaly. Hunter is mild hurler. Hunter is mild hurler. But it is patient will be having aggressive behavior. One more thing, one more major difference between them is about the corneal clouding. Hunter has to hunt. Hunter has to hunt, so there is no corneal clouding. Eyes should be very perfect. This is how you are going to remember. Whereas in hurler, there will be corneal clouding. So this is the major difference between them. Other than in the clinical case scenario, you will see the corneal clouding and no corneal clouding. Well, last time I remember one student specifically asked me, is there any specific difference in which we can figure out this is a Hurler syndrome? The Hurler syndrome patient, usually they will be having what? Hernia. They will be having hernia. Inguinal hernia often present. You can write this down for the worst case scenario when you are unable to figure the differences between them out. Okay, so now you have MPS 3A, B, C, D. All these are Sanfilippo syndrome. A, Sanfilippo syndrome. B, Sanfilippo syndrome. C, Sanfilippo syndrome. D. Then you have MPS 4A, MPS 4A, right? MPS 4A, MPS 4B. 4 is of two types and we call them is as Marquio syndrome A, B. Why I'm pulling this up? Here is the one where you have aryl sulfatase B. Aryl sulfatase B, right? In the one where you figured out aryl sulfatase A, that was sphingolipidosis, right? So just don't get confused. Sometimes in the rush, we pick a answer which looks very obvious, but and single alphabet difference in the option given make the difference. Really make the difference. It does, I'm telling you. Okay, so presence of mind is very important at that point in time. So after MPS 4A, 4B, you have MPS 6, MPS 7, and after MPS 4A, you have MPS 6, MPS 7, MPS 9, right? MPS 9 is Nato-Wiz syndrome. MPS 7 is Sir-7-Sly syndrome. MPS 6 is Matek's-Lemmy Matix Lemy. Depending upon various countries, you pronounce it differently. So you can pronounce it the way you want to pronounce. Okay. So why I want to discuss all this? First of all, know the Matix Lemy is the one. The deficient enzyme is aryl sulfatase B. Aryl sulfatase B. We have seen aryl sulfatase A there. So in rush, don't make a bad choice. Just be very careful when you are picking the choice. Why I want to discuss the Sly syndrome? Because in the Sly syndrome, the patient will be having the corneal clouding. Corneal clouding will be there. And I have already told you in the Hurler syndrome, patient is having the corneal clouding, right? So here is the corneal clouding, here is the corneal clouding. How you are going to make the difference between the Hurler and the Sly syndrome? First is the enzyme difference. In the Hurler, you have aldehydo-uranidase, where in this the defective enzyme is beta-glucuronidase. That is one difference. In up there, what you have seen, the dermatan sulfate and the heparin sulfate was precipitated. In this, you have the dermatan sulfate, you have the heparin sulfate, but other than that, what else is precipitated? Chondroitin 4 sulfate and the chondroitin 6 sulfate is also being precipitated in the Sly syndrome. So it is very, very easy to figure it out. The defective enzyme, right, heparin and other, these are extra. But the corneal clouding is the same. On that basis, you can figure things out. Now, the Hurler syndrome, MPS 1. So I remember very clearly the Hurler syndrome, like MPS 1 is of various type actually. MPSH, right, that is Hurler. And there is one kind MPSS, that is Schie, SCHEIE, right? And then there is a Hurler and the Schie combination, right? So how you are going to figure it out? This is Hurler or this is Schie. You have to figure the difference out, right? So Hurler, I said there is a mental retardation. Mental retardation. Inguinal hernia is there. In this case, there is no mental retardation. In this, you have the heparin sulfate and the dermatan sulfate that are being precipitated. In this, only the dermatan sulfate will be being precipitated. So note this as for the examination point of view. Okay, so now we know so many questions which are high yield questions just from one topic. We know sphingolipidosis, we know mucopolysaccharidosis, we know the Pompe's disorder, which is a lysosomal storage disorder. I want to quickly go over the mucolipidosis, that is I cell. That is I cell. That is the I cell. This is the characteristic like of the I cell. What do we see? The coarse facial features. Coarse facial features, skeletal abnormalities will be seen as seen here. Skeletal abnormalities and the severe mental retardation. Severe mental retardation. In the lysosomes, what we see here in the lysosomes, what we see there, these are inclusion bodies. Inclusion bodies. Why they are inclusion bodies? These inclusion bodies are accumulated in the lysosomes. Because lysosomes are the residual bags. Whatever comes in there need to get recycled. Who is going to recycle them? Lysosomal enzymes, which work at the acidic pH, What is so special about the lysosomal enzyme? After the protein translation, proteins like after the enzymes, these enzymes get translated, they undergo modifications. We call them as post-translational modifications or post-translational modifications. Even the lysosomal enzymes, they go through that. What they get is they get a very specific tag of mannose 6-phosphate. So those who get this mannose 6-phosphate are the ones which are taken to the lysosomes right, for the lysosomal degradation. And these enzymes, since if they are in the blood, right, while traveling, right, they are in the blood pH is 7, it is not like almost 7, it is not acidic, so they are not working. Acidic pH approximately 5 pH they need to work, so they are not working. But as soon as they reaches to the lysosome where they find the appropriate condition, they start working. So when the tagging is not done, right, when the tagging is not done, then what happens is everything keeps on accumulating, building up in the lysosome as it is shown here, right, and that is going to lead to the inclusion bodies formation in the lysosome. So mannose 6-phosphate tagging is the must. So in that case, in the eye cell disease, what you will find is you will find the elevated level of lysosomal enzymes in the blood plasma, and they are not working because they are not workable at that pH, right? So this was pretty much like so many questions from one topic, that is lysosomes, and very, very important. All these topics are very important and you must see 2 or 3 questions from this one, right? Now let's move forward. There is the 35-year-old male patient admitted to the hospital with complaint of what? 35-year-old with the abdominal pain, headache, diarrhea, and lead lines is found in the cum. So definitely we are looking something with the lead toxicity, right? Lead toxicity, where we get the lead exposure, the patient gets the lead exposure from. Lead exposure can be from many places. Maybe he's working from the factory, got exposed to the lead paint, right? Also the pottery glaze and the batteries, right? Exposure to them leads to the lead toxicity, right? And upon testing, he was found to be suffering from microcytic hypochromic anemia, right? Lead poisoning was confirmed by the physician, right? Which enzyme has been affected? So what we know, lead inhibits 2 enzymes, that is ELA dehydratase and the ferrochelatase, right? That is a fact. That is not going to change. So that is ELA. This is ELA synthase. This is not ELA dehydratase. So you're not going to pick it, but you are going to pick the ferrochelatase because it will be inhibited by the lead. It will be inhibited by the lead. Another one is ELA dehydratase. ELA dehydratase, which is the second step in the heme synthesis. This is the heme synthesis. This is the first step carried out by ELA synthase, in which glycine succinyl coenzyme may make delta amino levulinic acid, and deficiency of this enzyme, right, leads to anemia, sideroblastic anemia. Why sideroblastic anemia? If you look up close, it requires B6. So vitamin B6 deficiency, right, is going to affect this, and the patient will be suffering from sideroblastic anemia. That is also once asked, actually 2 times asked in the exam, so make note of this. And who is going to repress this? This enzyme is repressed by heme. What is heme? Heme is the end product. Heme is the end product. So end product inhibition. So end product inhibition, you can see. Okay. Now from delta amino levulinic acid, what do you make? You make the porphobilinogen by the enzyme ELA dehydratase, which is inhibited by the lead. And also the last step, the second and the 8th one, is inhibited by the lead. It is inhibited by the lead. So that is what is going on with the patient. Lead is inhibiting the ELA dehydratase. What else can be given? When the ELA dehydratase is there, there will be elevated level of delta amino levulinic acid. Also ferrochelatase will be inhibited, so there will be protoporphyrin elevated level. Sometimes they give you these levels in the exam. So lead toxicity, increased delta amino levulinic acid, and protoporphyrin. Also in case of enzymes, if this is exposure to the lead, but what if these enzymes are defective? If ferrochelatase is defective, right, that gives rise to porphyria known as protoporphyria, based upon the name of the substrate, that is a protoporphyria, and this is most common porphyria occurring in the children, most common occurring in the children, and this is non-blistering. Non-blistering meaning it has in this, right, this is blisters will not be formed in this, right? Now what else is there? LR dehydratase. LR dehydratase, if this is inhibited by the lead, and what patients experience abdominal pain. Abdominal pain. There is no such kind of a porphyria when the LR dehydratase is inhibited. Right, from porphinobilinogen to hydroxymethylbilane, the third step, there is one enzyme. Since you are making hydroxymethylbilane, enzyme is hydroxymethylbilane synthase, or you can say you are deaminating porphobilinogen, so porphobilinogen deaminase, right? So that is the same name of one enzyme. Product is hydroxymethylbilane, also known as uroporphyrinogen 1. How you are going to remember? This is the 3. Afterwards you are making 3. So this is the 1. And so the enzyme name, the third name of the enzyme is uroporphyrinogen 1 synthase. Uroporphyrinogen 1 synthase. Remember this. This enzyme has 3 names. Very, very important. Porphyria, if this enzyme is deficient. What is that porphyria? That is acute intermittent porphyria. That is what? That is acute intermittent porphyria, right? Which is autosomal dominant in nature, right? And that has late onset. There will be episodic things. There will be definitely what? The neurovisceral symptoms. Neurovisceral symptoms, but there is no photosensitivity. Mind this, there is no photosensitivity. Why? I'll let you know in a minute. There is no photosensitivity. And in these patients, another 2 important, like AIP has been asked, so no, there is no photosensitivity. One thing, right? These patients are never given barbiturates, because that will lead to the drug-induced porphyria. For barbiturates, right, to excrete the barbiturates, you have to break it down, and for that you need the cytochromes. Cytochromes are heme containing, so you have to synthesize the heme that will induce the porphyria. That so no barbiturates to the patients having the hydroxymethylbilane deficiency. And what else is there? It is exaggerated. It is exaggerated when and what is there? In some patients, you will see the port wine urine. That is acute intermittent porphyria, right? So next is hydroxymethylbilane converted into uroporphyrinogen 3, right? And that is enzyme is uroporphyrinogen 3 synthase. That leads to porphyria known as congenital porphyria, which is the most severe form of the porphyria. Uroporphyrinogen 3 to coporphyrinogen 3 enzyme is decarboxylase enzyme, right? And this is another very important, most commonly asked. This enzyme deficiency will lead to PCT, porphyria cutanea tarda. Right? If you compare, if you have to figure it out which one is the one in the exam, both are autosomal dominant, both have the late onset, right? It also have the neurovisceral symptoms, but it also contains the photosensitivity towards the light. It is exacerbated by the alcohol, and the patient urine will be red brown to deep brown, urine. So these 3 things: photosensitivity exaggerated by alcohol consumption, and urine red brown to deep brown is the PCT. Whereas in AIP there is no sensitivity, and we avoid giving the barbiturates, right? We avoid giving the barbiturates. So that is pretty much most commonly asked questions in the exam. So for example, let me randomly ask you something. The patient has a deficiency of hydroxymethylbilane synthase, that is strep3 enzyme is deficient. So what will be, which levels would be raised? There will be increased porphobilinogen, there will be increased delta amino levulinic acid, both will be raised. Delta amino levulinic acid will be raised almost in every except the ferrochilotase. But do you see, means whatever it is being converting, if this is not being converted, so that will raise the level of the substrate. That will raise the level of the substrate. Okay. This is a question in which the patient has a 40-year-old patient with the tingling sensation and the cracks on the lip borders and the corners of the mouth, right? So chiliosis we are looking at, or you can say stomatitis. Upon further investigation, he is found to be a heavy alcohol drinker, right? And last month he was treated with tuberculosis. In the tuberculosis, what we give? We give the isoniazid therapy, right? And we know whenever we give isoniazid therapy, there is decrease in pyridoxine or PLP or pyridoxine. This is the vitamin form, and when we say, we are talking about the coenzyme form. Which nutritional deficiency is suspected? Definitely very easy. It is the B6 deficiency which is expected. Now, the tingling sensation, the chiliosis, stomatitis. Which else is very close to this? That is another is the this is seen with the riboflavin deficiency as well. Riboflavin deficiency. Riboflavin is your B2, right? Coenzyme form is FMN, FAD. FMN, FAD, these are the two coenzyme form, and it works with most of the dehydrogenases. Right? It works with more, and what else you see? You see the corneal vascularization. Vascularization is seen in the patient. The corneal vascularization is seen in the patient other than the chiliosis, stomatitis. And there is one more fact. There is one more fact. That is what? That is your magenta colored tongue. Magenta colored tongue. Again, one of the recall questions. So remember, chiliosis, stomatitis, tingling sensation does not mean just the riboflavin. You have to look for other things. Isoniazid therapy, vitamin B6 deficiency. If there is a corneal vascularization and magenta colored tongue, then you are going to pick the riboflavin deficiency, right? So this is one part. Now, there are other things that is very closely related to all this, right? Why? Because when you have the vitamin B6 deficiency, patients suffering from the vitamin B6 deficiency, they develop sideroblastic anemia. Sideroblastic anemia. One part. Another question that was once asked was which enzymes uses vitamin B6 as a coenzyme or PLP as a coenzyme. So you should be knowing that the aminotransferases or deaminase or transaminases, right? Aminotransferases, your ALT, your AST. They utilize vitamin B6. Also, delta amino levulinic acid synthase. right? The very first enzyme we have just seen, right, in the heme synthesis, that also utilizes B6. So that is giving rise to the deficiency, is giving rise to the what? Anemia, because heme is not formed. What kind of anemia? The sideroblastic anemia. Sideroblastic anemia. Okay. Now, many a times there are clinical scenarios given in which we are confused which one is what, whether it is a B6 deficiency based upon the anemia, or an iron deficiency, or the lead poisoning, because in all of these three you will find the microcytic anemia. Same in all of them, they have the microcytic anemia. In the lead poisoning, however, what we see is the coarse basophilic stippling in erythrocyte. Coarse basophilic stippling in erythrocytes. That what we see, right? In vitamin B6 deficiency, you see the ringed sideroblasts in the bone marrow, which you don't see in the iron deficiency, but you do see same in the lead poisoning. Still we are on the same page. What about the ferritin and the serum iron level? In case of the iron deficiency, what do you expect of the ferritin and the serum iron levels? It is gonna go down in the iron deficiency. But in vitamin B6 deficiency, there will be these levels will be up. Why these levels will be up? Because now the iron is not being used towards the synthesis of the heme. Vitamin B6 is required for the very first enzyme in the heme synthesis. If it is not working, right, the B6 is not there, that first enzyme is not working, and that will lead to the elevated levels of the ferritin and serum ions. Make sense? What about the lead poisoning? Same thing happened in the lead poisoning. Lead poisoning also halts the entire heme synthesis pathway. In this, the ferritin and the serum and level ions will be the upper ones. Very easy. Now, how about protoporphyrin and delta LA? Delta amino levulinic acid, right? The protoporphyrin levels in the vitamin B6 deficiency, it will be low. Why? Because the first enzyme is not working, so the rest products will not be formed. The lead products will not be formed. Whereas in the lead poisoning, the step is the second one. So you have the delta amino levulinic acid, which is already formed. That is the first step. It will form, right? It will form. And also the protoporphyrin levels will be up also, because they are not being taken into the ferrochelatase, right? So it varies. This one all is questionable, but this definitely delta LA is being first. But if there is too excessive exposure, that stops negatively inhibit the first enzyme also, then in that case you will don't see the delta LA. So, but ferritin serum ions will be up. There will be microcytic anemia. There will be ring sideroblast in the bone marrow. What about in the iron deficiency? In the iron deficiency, what you will be having, delta LA will be normal. This will be normal, whereas the protoporphyrin levels will be up in the case of the iron deficiency. So based upon these facts, you can distinguish between whether it is a B6 deficiency, iron deficiency, or the lead poisoning, right? B6 deficiency, another keyword is the isoniazid. That causes vitamin B6 deficiency. So if the patient has been treated previously for the TB in the recent timings, that means he must be vitamin B6 deficient if it is not stated that B6 supplements were given, right? So if the question says so, you have to be very, very careful. Dietary iron deficiency leads to the deficiency in the dietary deficiency, right? Lead poisoning, I have already told you, because of the lead paint. Lead paint contains it, right? And the glaze, ceramic glaze, and the batteries, they contain it. So now it's very easy to compare and find out the correct answer in case you have a complicated case scenario. Now there was this question which I find very interesting, right? So I picked it up for you guys. A woman 7 months pregnant develops the anemia, right? There was increased mean cell volume, hypersegmented neutrophils, and the altered morphology of several other types. Most likely underlying cause of this woman's anemia is anemia, right? So folate deficiency, iron deficiency, vitamin B12, lead poisoning. So it cannot be iron deficiency. For lead poisoning deficiency anemia, because it is a sideroblastic anemia, this probably may be pregnant women, whatever that is, increased mean cell volume, so she is probably having the megaloblastic anemia. And megaloblastic anemia is both because of the folate as well as, both for the folate as well as the vitamin B12 deficiency. So how to figure it out? Pregnancy definitely indicating a biggest risk factor, like biggest thing is the folate deficiency, because body is synthesizes nourishing the fetus. Lots of DNAs are being made. Lots of the DNA process is very high, and that DNA requires synthesis, requires purines and the pyrimidines. They require tetrahydrofolate. In our body, we cannot make the we make the tetrahydrofolic acid from the folic acid. Given the condition, folic acid is provided in the diet because our body is incapable of synthesizing the folate. Bacteria, they do synthesize the folate, but we take it in our diet. So major, if it says the pregnancy, so we most probably it is a megaloblastic anemia with the folate deficiency. But still, this question is just a simple question. You may find a complicated thing. I want you to figure things out based upon other facts also. Folate, just learn these facts. Folate deficiency and the vitamin B12 deficiency. Vitamin B12 is the cobalamin. Right? In both the cases, the patient is having the megaloblastic anemia. Megaloblastic anemia. Right? This also has. Right? The macrocytic, the mean macrocytic, mean MCV is greater than 100 femtoliters in both the cases, right? And there will be PMN more than 5 lobes. Same is true in here up to this point, right? But there will be homocystinemia. Homocystinemia in case of the folate deficiency, which is also there in the vitamin B12 deficiency. Homocystinemia, know this, is related to increased risks of cardiovascular disorders, right? That is, homocystinemia is another topic I don't want to discuss here, but still, if you get a question, this is the key point. Homocystinemia is related to the increased risk of cardiovascular diseases, right? And in the folate deficiency, that it is developed within 3 to 4 months, right? And the risk factor, major risk factor is the pregnancy. Right? Other is alcoholism also, but not so much. Vitamin B1 deficiency is also because of the alcoholism. Okay, so you have to pay attention to the other features given to us in the question paper, right? Then there is severe malnutrition. These are the major ones. For the vitamin B12 deficiency, what extra thing you have the methylmalonic acid urea. Methylmalonic acid urea is the one that we find in this one, right? And methylmalonic acid urea is always associated with the progressive neuropathy. That is always associated with the progressive neuropathy. And the risk factors which causes the vitamin B12 deficiency is the pernicious anemia, right? Definitely there is any kind of the gastric resection or chronic pancreatitis that is being happening, right? There is a severe malnutrition in the vegan. They have vitamin B12 deficiency also. So those are the risk factor. But if you have to find the difference is the methylmalonic acid urea, which is there in the B12 deficiency, right? B12 deficiency. Homocysteine urea in the folate deficiency also. Homocysteine urea in the homocysteine urea. Write this thing down. There will be decreased folate. There will be decreased B12 and also there will be decreased vitamin B6. All three things. All three things. For the detailed thing, just refer to the lecture when we discussed about the homocysteine. Okay, so this was pretty much about so much actually about comparing and finding the vitamin B6 deficiency, iron, lead poisoning. Most of the time we are confused between the folate and the B12 deficiency. Next is the thiamine deficiency leads to lactic acidosis. Which enzyme would be affected by the thiamine deficiency? Also increased lactic acidosis, right? So thiamine deficiency. Thiamine is your vitamin B. Thiamine is your vitamin B1. Vitamin B1 is cofactor thiamine pyrophosphate or thiamine diphosphate. These acts as a coenzyme for what? Pyruvate dehydrogenase. Alpha ketoglutarate dehydrogenase. What else? Branched chain keto acid dehydrogenase. All those dehydrogenase and transketolase. This is the standard fact. You have to just know this. All these important dehydrogenases and also the transketolase in the HMP shunt, right? They all require vitamin B1. That is why, and what all these enzymes are related to the energy production. So deficiency of vitamin B1 make the patient feel very lethargic because energy is not being produced in the body. So answer to this is the choice A. What else you have? The pyruvate carboxylase, phenol pyruvate carboxykinase, PC, PepsiK, PC, right? PC, and all these carboxylases, they require biotin. I should write this, carboxylases. This was one asked. They require cofactor biotin, right? PepsiK enzyme. PepsiK enzyme does what? This enzyme converts oxaloacetate to phenol pyruvate, phosphoenol pyruvate in the gluconeogenesis. That do not require access something, but there are ions required, magnesium ion on the manganese ions, right? And it is ATP dependent, right? So this is pretty much it. So answer to this is the pyruvate dehydrogenase. Okay, I have one more thing for you guys. So that, and what I want to tell you here is, in rush we make major mistake about the alcoholism. You see, thiamine most common cause is alcohol. Folic acid deficiency, main alcohol is the major cause in both of the cases, because the alcohol interferes with the absorption of the thiamine and it depletes the level of the folic acid in the body, right? But in folic acid, what we are looking for? We are looking for the pregnancy. In the pregnancy, in the thiamine, either we will find out which enzyme is the marker enzyme. Marker enzyme is transketolase. And the beriberi disorder, though the pregnant lady, if the pregnant lady has a thiamine deficiency, that will lead to infantile beriberi also. But the signs and symptoms will make it more clear. Whether it's a dry beriberi, wet beriberi, Wernicke-Korsakoff syndromes, right? Or Wernicke encephalopathy like confabulation, the patient will come up with something. These are the chronic alcohol, but definitely not the pregnant lady. Pregnant lady with the alcoholic issues, we are looking for something that is folic acid, right? Folic acid is required majorly by the thiamidylate synthase enzyme, right? During the synthesis of the deoxynucleotide, right? When deoxynucleotide one, which contains thiamine, right? Methylthiamine, you need to add a methyl group that is taken care by the thiamidylate synthase, which needs a methyl group. Tetrahydrofolate is going to give the methyl group. Another methyl donor is SAM, S-adenosyl methionine, right? But the major one in this case is the tetrahydrofolate, and our body cannot synthesize the tetrahydrofolate. We need to have it in diet, otherwise it will lead to NTDs, neural tube defects in the pregnant lady. Okay, thank you very much, and I wish you a very good luck for the upcoming exam. Just keep studying, work hard. Always remember, nobody is going to motivate you. Maybe sometimes your teachers or maybe your friends will say you have to work hard, but the biggest key factor to work hard is your own